This is One-on-One. Dr. Ronald Matteotti is a surgical oncologist, Meridian Cancer Center. Good to see you, doctor.
Thank you very much for having me.
Let's talk minimally invasive surgery, area of expertise, surgical oncologist. But I keep asking myself this, is minimally invasive surgery, when you're dealing with a patient with cancer, is it different in any way, or do you deal with it differently when a patient has cancer?
Minimally invasive surgery is a technical approach to any disease site, like in the benign area or malignant area, if you have cancer or non-cancer. It's basically what we call keyhole surgery. And patients have a much greater benefit in terms of recovery, of bowel function, second day after surgery. They're most likely already on a regular diet, have no pain almost, or pain is very well controlled. So if you talk about cancer, it's even more interesting in applying this new technology because,
why is that?
Because you have smaller incisions. Immune function is preserved, so patients are battling their post-operative stress much better. And if you have smaller incisions, we can plug, if you have an unexpected finding, especially if you operate on colon cancer, and the pathologist stages the specimen afterwards and tells us, hey, this patient needs chemo. We can plug in the patient right away, a week later, into chemotherapy, life-saving treatments. While if you have traditional surgery, so there's a big incision, you got to wait for up to 6 weeks.
Doctor, do this for us. For people, it's been called keyhole surgery, but putting things in perspective, because people actually think in a keyhole, right? Put it in perspective what it was, a surgical oncologist. You go in, what would be the normal, the traditional incision, and what are we talking about now, and give people that perspective.
If you talk about pancreatic surgery, what I do for a living, it's or liver surgery. Traditionally, you had a big incision from below the costal margin, from left to right, which is
from where to where?
From the left to the right.
Across
over, or full midline, which is almost like a 25-30 centimeter incision. You cross through the muscles, you cut the muscles. You have a lot of complications potentially to deal with in the postoperative phase.
Because the organs we're talking about, you've got to get to them.
You've got to get to them. So if you do laparoscopy, minimally invasive surgery, we put in a camera at the umbilicus, at the navel, and just look around. We create a space with CO2. So
with what?
With CO2. We inflate the abdomen.
You inflate the abdomen.
Inflate.
You go in.
We make a little hole, put the trocar in like a cannula, put the gas tubing on, and inflate the abdomen. So you have a space. So we have a 2D picture, and you work in a 3D space.
And you're able to. Are you able to do virtually everything you were able to do with the other kind of surgery?
It's a misconception that every cancer is amenable to minimally invasive surgery.
Not every cancer is.
Not every cancer. It depends on the extent. I mean, if you look at so-called sarcomas, which are like large cancers in a space of the abdomen, which sometimes take over like 2 or 3 kilograms, I mean, that's absolutely not accessible to minimally invasive surgery. But the regular stuff, pancreatic surgery, colorectal cancer, that's absolutely should be state of the art.
So let me ask you this. This book, describe it, who worked with you on it, and who was it for?
The audience is for professionals, students, fellows, and people who want to immerse themselves into this technology. So in 2006, we set together, I had the great pleasure to train with one of the world leaders in minimally invasive surgery. So from a technology standpoint, a lot of stuff is done. So you can't really explore any more cavities in the abdomen put in a cannula or like a TV camera.
Right.
So we were thinking about what's going to be the next best step in minimally invasive surgery, and we tried to combine a disease site, a disease process with a technology approach, and that's where this book came in. So that's what we did.
Now your team, the Meridian Cancer Care team,
yeah.
Who's on it and why are they on it?
The leadership is under Dr. Mark Krasna, corporate leader of Meridian Cancer Care. I'm leading the pancreas and liver division, and we're adding more and more surgeons right now. 2 others coming on board right now for thoracic oncology. And we all are specialists in minimally invasive surgery.
Talk about a team. It's interesting, this team approach, right? All these different players on this team. Why is that so necessary?
Cancer care, you can't do it alone. Cancer care is always a battle on three frontiers. So you have like surgery. If you can cut it out, it's best. I mean, you can get what we call an RC or a resection. You have local control. But if you can't have that, you got to have some systemic control. Some cells could have shed, so you got to have chemo doctor taking care of that. On top of that, you need radiation oncology. These are the three clinical specialists working on a cancer team. And what we're trying to do, our like door to treatment time is usually 7 days. If a patient hits my office, we're going to have a preliminary treatment plan for you in less than 7 days.
And that whole customized plan, I guess, what is the term?
Personalized care.
Tailored patient care?
Tailored
what does that
patient
mean?
care. So if you come to me, Steve, and you have a cancer, and I'm going to look at all the stuff, define if you need further workup, talk to my colleagues from Hem-Onc, talk to my colleagues from radiation oncology, and then we come back together on an interdisciplinary tumor board. More times like last week, I wanted to do surgery on a patient, and I thought this patient is absolutely a surgical candidate, but the team felt strong. We should approach this patient differently in a multidisciplinary approach and give him what we call chemotherapy and a new trial we're opening up right now up front, which gives them a better shot on a 5-year survival. So we really look at the individual patient and tailor their patient care.
It's important to do that.
Yeah.
Doctor, I want to thank you for joining us. Dr. Ronald Matteotti,
Yes.
surgical oncologist, Meridian Cancer Care. We appreciate you shedding light on this very important topic, minimally invasive surgery, dealing with cancer patients. Your expertise, again, is pancreatic.
Pancreatic and liver, yeah.
Thank you, Doctor. Appreciate it. Stay right there. One-on-one, we'll be right back right after this. Thank you, Doctor.
One-on-One with Steve Adubato has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence. Funding for this edition of One-on-One with Steve Adubato has been provided by Choose New Jersey, New Jersey Credit Unions, AmeriHealth Caritas, parent company of Perform Care, New Jersey Natural Gas, Activus, in cooperation with the American Medicine Chest Challenge, New Jersey Manufacturers, and by the Russell Berry Foundation. Promotional support provided by the Star Ledger, powering NJ.com, and by Commerce Magazine. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area.